and graduates and undergraduates. Today's topic is hyperemesis gravidarum. Hyperemesis gravidarum, nausea and vomiting of pregnancy. How is NVP diagnosed? Onset in the first trimester and other clauses excluded. After 80% of the pregnant women, how hyperemesis gravidarum diagnosed? Protracted NVP with more than 5% weight loss, electrolyte imbalance, and dehydration. Affect 2 to 3% of the pregnant women. Hyperemesis gravidarum, these are the risk factors: previous pregnancy with hyperemesis gravidarum, nulliparity, multiple gestation, trophoblastic disease, greater body weight, more common in industrialized urban areas than rural areas. Risk is reduced with advanced maternal age. Now, this is the case scenario. 26-year-old primigravida, 7 weeks gestation, excessive salivation and heightened sense of smell, vomiting since 1 week, not able to tolerate food. Nausea, vomiting of pregnancy, these are the green top guidelines. Typically, onset is between 4th and 7th weeks in the 9th week. If it starts after 10 weeks, other causes should be ruled out. Affects 80% of women. And how to manage this type of simple cases: primary care, outpatient basis. No signs of dehydration. We need to give her reassurance, support, oral hydration, dietary advice, and antiemetics, especially doxylamine, succinate, pyridoxine. Now, this is the case scenario. Same patient, 2 weeks later, women presents with the persistent vomiting, appears dull and lethargic, BP on the lower side, loss of weight, 3 kg. Now, this is the hyperemesis gravidarum diagnosed when protracted NVP with a triad, more than 5% pre-pregnancy weight loss. Number 2 is the dehydration, and third is electrolyte imbalance. Severe form of NVP affects 0 to 0.3 to 3.6% of pregnant women. Now, the signs, symptoms, mainly gastrointestinal, nausea, vomiting, tylism, excess salivation, fatigue, weakness, dizziness, sleep disturbances, hyperolfaction, dysgeusia, and mood changes, anxiety, and irritability. Now, what do we have to look for this type of patients? Number 1, hyponatremia. Number 2, hypokalemia. Number 3, low serum urea, raised hematocrit, ketonuria, severe cases, metabolic acidemia. Abnormal thyroid functions test and abnormal LFT, transaminase. Now, this is the ambulatory care management, day care management. When primary care measures have failed, PUQE scores is less than 13, parenteral fluids, parenteral vitamins, and antiemetics. Now, the inpatient management presenting with at least one of these symptoms: continued nausea and vomiting, inability to keep down the oral antiemetics, associated with ketonuria and overweight or weight loss despite or oral antiemetics, confirmed suspected comorbidity, UTI, inability to tolerate oral antibiotics. These are the green top guidelines of 2016. Now, the management goals: determine the severity, correct the hypovolemia, reduce the symptoms, and prevent the complications. Classify the severity of NVP by PUQE, that is a pregnancy unique quantification of MSS score, an objective and validated measure for the severity of nausea and vomiting. This PUQE score index, total score, is a sum of replies to each of these 3 questions: mild, less than 6, moderate, 7 to 12, and severe, 13 to 50. Mother risk PUQE is 24 scoring system. These are the questions which we should ask to the patient. In last 24 hours, how long have you felt nauseated? Not at all. 1. A 1 hour or less. 2. 2 to 3 hours. 3. 4 to 6 hours. 4. And more than 6 hours. Then 5. In last 24 hours, have you vomited or thrown up? 7 or more times. 5. 5 or 6 times. 4. 3 or 4 times. 3. 1 to 2 times 2. And I did not thrown up is a 1. In last 24 hours, how many times have you had retching or dry heaves without bringing anything up? No time. 1. 1 to 2 times 2. 3 to 4 times 3. And 5 to 6 times 4. And 7 or more times is 5. Now this is the evaluation, test and what to look for. Urine analysis for ketones and pus cells, for electrolytes, hyponatremia, hypokalemia, and hypochloremic alkalosis, and creatinine, pre-renal or the renal failure. Now full blood count for the infection, anemia, hematocrit, thyroid stimulating hormone, blood glucose monitoring. Exclude diabetic ketoacidosis if diabetic. Now sonography, confirm viability, exclude multiple gestation, trophoblastic disease. Now the management medication that can be used, vitamins, pyridoxine, antiemetics, especially the doxylamine, then chloropromazine, then metoclopramide and ondansetron. Acid reducing agents, omeprazole. Antihistaminic drugs like diphenhydramine, and herbal medication like a ginger, and corticosteroid in a severe cases. Safety and efficacy of pharmacological agents. First line treatment, antihistaminics and vitamin C. Second line treatment, metoclopramide and ondansetron. Combination of drugs when no response to the single agent. Third line, corticosteroid when standard therapy has failed. So the ondansetron, that is a 4 milligram to 8 milligram BID to QID, IV, category B. Metoclopramide, 5 to 10 milligram BID to QID, IV or intramuscular. Then promethazine, 12.5 to 25 milligram IV or intramuscular BD to QID, category B. Now adjuvant therapy, acid reducing agents, omeprazole, 20 milligrams twice daily. Now the rehydration therapy is also important. Ringer lactate solution, normal saline, additional potassium chloride in each bag. Hypovolemia, 2 liters over 3 to 5 hours. 2 ml per kg per hour or 125 ml per hour. Infusion rate adjusted to maintain output. More than 1 ml per kg body weight per hour. So this is the rehydration therapy. Dextrose infusions to be avoided in initial replacement fluid. Concerns of vernix and continuous hydration maintained with a dextrose containing solutions, potassium supplementation, 20 milliequivalent per kcal. Now, if hypokalemia is severe, potassium is added to IV fluids to achieve concentration of 40. If infusion rate is 10, then the potassium per hour is safe. Now, the supplements, thiamine, 100 milligram daily, 2 to 3 days, oral thiamine, then multivitamin infusion daily. Now, the case scenario continued. Women readmitted after 1 week, continuous vomiting, unable to retain medication, weight loss is 6 kgs, and there is an altered sensoria. Now, in refractory cases, repeat admission, LFT increase in a amino acid transferase seen in 50% of admissions, amylase and lipase, ABG exclude metabolic disturbance to monitor severity, and refractory management is very not that easy, but easy. Hydrocortisone 100 milligram IV, switch to oral steroid, tap hydrocortisone, and then oral thiamine, injection thiamine for 2 weeks. Now urea and serum electrolyte daily, input and output chart, avoid iron preparation. Thromboprophylaxis with low molecular weight heparin unless contraindicated. If persistent dehydration, electrolyte loss, weight loss despite all measures, nutritional supplementation by either parenteral or enteral route is indicated. Standard method is via total parenteral nutrition, risk of sepsis, bacteremia and thrombosis, and nasogastric tube replacement with enteral feeding. Now the hyperemesis is a diagnosis of exclusion. Look for other causes: peptic ulcers, cholecystitis, gastroenteritis, hepatitis, pancreatitis, and genitourinary conditions and neurological conditions also, and sometimes drug induced. Now, complementary home remedies are ginger, ginger lollipop, ginger tea. Then acupressure and acupuncture is also can be used. Effect of ginger on nausea and vomit in early pregnancy, a meta-analysis and conclusion, it's a very good, we can use it. The efficacy of acupressure for the symptoms of management review. Conclusion is the inclusion of acupressure as intervention may improve the patient's outcome. Now the dietary changes: gut rest avoid, triggers diet, eat before as soon as hungry, eat slowly, then frequent small meals, avoid coffee, substitute with protein dominant, salty, bran, dry, low fat food, and eliminate iron pill from the diet and medicine. Increase intake of carbonated beverages. Others suggest food include herbal tea with a peppermint, ginger, unbuttered toast, frozen desserts. High protein sex are sometimes helpful. Preconception use of prenatal vitamins may decrease nausea and vomiting in a pregnancy. So the fluids consumed in small quantities 30 minutes before and after the solid food. And the salivation, frequently washing mouth, brushing with mint flavored toothpaste are there. There are sometimes the complications: wernic encephalopathy, maybe mental confusion, ataxia and ophthalmoplegia, esophageal laceration with hematemesis, this is a Mallory-Weiss syndrome, renal dysfunction, pre-renal failure, central venous thrombosis secondary to dehydration, and psychological effects, feeling that caregivers did not realize how ill they were, fear of subsequent pregnancy, negative attitude towards that pregnancy, post-traumatic stress, difficulty in milk secretion, marital issues, and this is a case report describing the following complication: esophageal rupture, pneumothorax, wernicke's encephalopathy, hepatic disease, deep venous thrombosis, seizures, coma, and death. So the fetal outcome: preterm birth, low birth weight, manifest first time in a second trimester, increased risk of preeclampsia, transfer to higher center. These type of patients, if there is a presence of hematemesis, if there is a neurological complication like altered sensorium, then refractory cases requiring parenteral nutrition, and sometimes renal failure is there. Initial assessment by PU-QU score, assess clinical complications, dehydrations, exclude other causes. PU-QU 3 to 12, no ketonuria, antiemetics first line treatment and dietary changes. If PU-QU is more than 30, no ketonuria, ambulatory daycare, second line antiemetics, oral, parenteral and parenteral hydration. If PU-QU score is with a complication, ketonuria plus, inpatient management, second line of antiemetics, steroids, rehydration, thrombophlebitis. So the role of multidisciplinary team is there, holistic approach. Nurses and midwives should be worried about, dietetic advice. Then there is a physician, endocrinologist is needed whenever it's needed. Then the psychological support from the family and the counselors, and mental health team should be there. So these are the Green Talk Guidelines 69 June 2016. These are the references. And thank you so much for the patient hearing. Thank you so much. Today's topic was important. Thank you so much.